Hi, everyone. It's time to talk about some knee disorders. Put my guy in the background here. We only have 3 to discuss, and even though they are knee disorders, they're more like knee surgeries, and they're common knee surgeries. So I'm not going to go into great detail about the surgery itself. I really want to focus on your role as a massage therapist and supporting people who have had these knee surgeries, because you are definitely going to see them in your practice. All right, here we go. So, come on. There we go. This is the Word document in Module 6. That corresponds with what we're talking about right now. Guess I'll bring that up. Yeah, full screen. Let's do the full screen. That sounds good. Okay, so knee disorders. The first one that we have is an ACL reconstruction / repair. So we've talked a little bit about the structure of the knee. So you know that the ACL and the PCL go like this, right? They are cruciate ligaments. They form a cross in the knee. The ACL is more likely to tear than the PCL. So this typically occurs during traumatic or athletic injury events, okay? Car accidents, soccer playing, football, oh my goodness, yes, lots of football injuries. I guess baseball sometimes. But anyway, the point is that if that ligament snaps, then it does require surgery, obviously. Reconstruction involves the ACL only. Okay, so that's just repairing the ACL if it can be repaired, or using a different piece of ligament in place of the ACL. Repair involves a part of the bone that was broken off along with the ACL. Well, that does happen sometimes. So the ACL itself can snap, or it can tear from the bone. But when it does that, it actually takes a bit of the bone with it. So that's the difference between repair and reconstruction. So if somebody says, oh, I had an ACL reconstruction, you know that it only involved the ACL. If somebody said I had an ACL repaired, then it involved the bone too. Ultimately, when something like that happens, you hear a pop. I mean, it's pretty loud. And you immediately go down and there's pain, and then swelling occurs shortly thereafter, and you know you did something. Okay, so what's next? They do an MRI. You have to have surgery. So there's a couple of different options. An autograft, they may need to use one of your own body parts, like part of the patellar tendon. They actually do use that. Sometimes a hamstring tendon can be used to reconstruct the ACL. So they just take a bit of your own parts and use them. You can have an allograft, and that would be a donor graft. So it's a cadaver most of the time. People don't usually donate tendon or ligament, as far as I know, while they're alive. So this is mostly cadaver parts. So once the surgery has been completed, they're immediately going to go into physical therapy. So you will probably not see them until after they are finished with PT, which is 6 to 8 weeks, maybe longer, depending on how they're doing with their PT. So you're really, and that's fine, because as a newer massage therapist or somebody who's new to the field, you don't really want to be working with somebody who's newly post-surgical. You want to make sure that they have had time to heal, that nothing is going to be compromised by the work that you do. So definitely you're going to wait 6 to 8 weeks after their surgery anyway, okay? They are going to have limited range of motion. So you're not going to do any range of motion activity with them. That's for their PT to do. And they usually have exercises that they have to do at home as homework anyway. So you're going to basically support the healing process. You're going to work on the quads, the hamstrings. You're going to work on tibialis anterior, gastrocnemius, soleus, everything that surrounds the knee in general. And you're really only going to be doing Swedish. So gentle, supportive massage for healing. Okay. Later, you can do some scar tissue work if you know how to do it. Okay. You might have to get a softer bolster for under the knee. Sometimes the bolsters feel a little hard underneath a knee that has had surgery. Sometimes it feels a little weird to the client, so you might need a rolled up towel instead, or one of the soft squishy bolsters. Meniscal repair is similar to ACL repair. The medial meniscus is the one that is mostly injured or torn just because of its position and the fact that it's a little thinner. I had mentioned that before. And because of its C shape. Excuse me. It can occur with a ACL tear or with any other knee injury, actually. And it can happen really for no apparent reason. Sometimes you step and turn and all of a sudden you have this sharp pain in your knee. Sometimes it can be something real simple, like a very minor car accident. My mother actually was, I'm going to say T-boned, but that's not really what happened. The driver of the other car did hit her car at the driver's side door, but it was so minor that it barely left a dent on her car. However, it was enough to knock into my mom's knee, and it actually tore her meniscus on that side. So, pardon me. So sometimes it doesn't take a whole lot to tear a meniscus, and that's not to say that they are weak. They're not. It's just that as we age, things start to dry out, and the knee is no exception. Specifically, the tissue in the knee actually gets a little drier and harder as we age. So it's more easy to tear later in life. Pain and swelling are really the main symptoms. With a meniscal tear, the swelling doesn't subside. It'll swell up and then it'll stay swollen for a really long time. And part of the reason for that is because menisci are avascular. They don't have their own blood supply, like ligaments. So in order for this to heal, the menisci actually have to absorb the nutrients that they need from the surrounding fluid, and that takes a long time. So really, if you're going to have if you have a meniscal tear, you'll probably need surgery. The good news is that it is arthroscopic surgery, which means that they don't have to cut the whole knee open to do it. They just go in, they make little incisions, and they go in with their tools and they repair it, sometimes robotically, actually. And then you're done. Now, as far as massage is concerned, it's really the same as ACL. You know, you have to be careful with range of motion. You have to be aware of the post-surgical implications. So you really wouldn't want to see them until 6 to 8 weeks out anyway. Gentle Swedish, supportive, nurturing massage. Last but not least, we have total knee replacement. Total knee replacement is just what it sounds like. You are replacing the end of the femur and the head of the tibia. So this is what it looks like. Okay. This is a knee. So this is what it looks like from the posterior. See the lovely chrome knee here and their fake menisci. This is what it looks like from the anterior. Someone has just made a cut here so you can see what exactly gets cut off. Okay. They'll take the whole top of the tibia off and hammer in this metal bit. And it kind of depends on what type of knee you get, what piece will fit on there. They have to make sure that it fits before they hammer it in and screw it in. So it's actually pretty brutal what they do. I'm not going to go into detail, but if you can see this image, you can see how far down into the bone it goes. Okay. And then, of course, this piece should fit nicely over the condyles of the femur. All right. Now, we're going to be talking about why people have total knee replacements. So this is a good picture to show you. Osteoarthritis is normal, regular arthritis. It is a wear and tear of the joint. And this happens over time. So by the time you're 40, nearly everybody has some kind of osteoarthritis somewhere in their body. Sorry, it's true. It doesn't mean that it's causing you pain or you need to do anything about it, but over time, osteoarthritis does get worse. It doesn't get better. And this is what it ends up looking like. It wears away the cartilage on the articular surfaces. When that happens, it becomes inflamed and you end up grinding bone on bone. Bone on bone, of course, is very bad. You don't want that to happen, but that's what ultimately occurs in late stages of osteoarthritis. And so replacement parts are needed because you don't want that grinding bone on bone. Eventually you won't be able to walk, and it's very, very painful. So, oh, come on, need to go back. There we are. So the most common cause is osteoarthritis, as I mentioned. Other causes are different kinds of arthritis, like rheumatoid arthritis, which is an autoimmune disorder, trauma, of course, genu varis and valgus. You know, we had mentioned that when we talked about those. So the symptoms, of course, are going to be pain and more pain, really. Some swelling. The swelling could be mild, but it will eventually become chronic. So the longer this goes on, the less and less the swelling subsides. And you'll notice it. One knee will be bigger than the other, and it'll feel like it's swollen. Now, here's the interesting part of this. Symptoms worsen with activity, but also worsen with no activity. So people with osteoarthritis have to find the balance. They have to find that line where it's enough activity that keeps their joint lubricated, but it's not too much activity that makes it irritated. And you can't just not do anything at all, because then the joint gets stiff and the fluid doesn't turn over within the joint itself, and then you have a whole other host of problems. So treatment, physical therapy, well, sure, absolutely. Once you get your total knee replacement, you're going straight into physical therapy. They will have you up and walking the very next day because they don't want the scar tissue to settle in. It's just like a hip replacement in that way. You got to get up and moving the very next day. NSAIDs, yeah, physical therapy prior to the surgery might be helpful. Cortisone injections, yeah, up to a point. You want to prolong the surgery as long as you can, because replacement parts like this are only good for 20 to 25 years. So the younger you have to have a replacement, the more likely it is that you'll have to have another one later in life. And you may not be a candidate the second time around. You know, it just depends on how good the rest of your health is if you need a second replacement. So massage, same as ACL repair, right? It's going to be supportive. It's going to be gentle. I have worked with many knee replacement clients, and even 6 to 8 weeks out, their knee is still swollen. So you are going to want to keep that in mind. It's going to be very gentle massage, gentle effleurage, no deep Swedish, no petrissage, none of that kind of thing. It's just going to be supporting the healing process. As the tissue swelling reduces, again, over time, maybe 16 weeks out, then you can use more I'm going to say vigorous Swedish. You can use maybe a little petrissage, but still the goal is to support the healing process. Later on down the road, maybe a year later, when everything is fully healed up, then you can start doing maybe a little deeper work in the quadricep and hamstring group to help balance out one side from the other, because of course the side that had the surgery is the side that's going to be favored, and therefore the body is going to create a little bit of an imbalance just simply because one part hurts and the other side doesn't. Okay. We'll talk about that concept a little bit more when we talk about adapting to injuries later on in the program. All right. But for now, all you need to know is gentle, supportive massage. Got it? Gentle, supportive massage for any post-surgery, not just knee, but people do have a lot of knee surgeries, so you're going to see this quite a bit. If you have any questions, post it in the discussion board. I'd be happy to answer them for you. See you later.